Assalamu alaikum. I'm Dr. Rawan Hamarji. The longer I spend in medicine, the less I believe that our biggest challenge is information. That may sound strange in a profession built on knowledge, but hear me out. Never in the history of medicine have we had greater access to information than we do today. We carry entire libraries in our pockets. Every guideline is available within seconds. Every lecture can be replayed. Every recommendation can be looked up. In theory, we should be the most informed generation of physicians that has ever existed. Yet, if information alone were enough, residency would feel much easier than it does. The reality is that many residents finish reading a chapter, close the book, and a few weeks later discover that large parts of it have quietly disappeared. Others can recite facts beautifully, yet struggle when those same facts arrive disguised as a patient rather than a paragraph. Many of us have experienced the unsettling feeling of recognizing something during an examination, knowing that we have studied it before and still being unable to retrieve it quickly enough to use it. Over time, I became fascinated by that gap. The gap between exposure and understanding, between recognition and retrieval, between knowledge and clinical judgment. What surprised me was that the answers were not found only in medicine, they were found in neuroscience, cognitive psychology, educational theory, and the study of expertise itself. Researchers such as Rodiger and Karpicki demonstrated that memory is strengthened not primarily by review, but by retrieval. Bjork showed that learning becomes more durable when it is made slightly difficult rather than perfectly comfortable. Speedy's work on spacing demonstrated that knowledge survives longer when encounters with it are separated across time rather than concentrated into a single session. Alan Pivio showed that information connected to both visual and verbal pathways becomes easier to recall. Clinical reasoning researchers such as Bourdard and Lajoie demonstrated that experienced physicians do not think in lists. They think in networks of relationships, mechanisms, and illness scripts. Cross-Carey works reminded us that many diagnostic errors arise not from ignorance, but from cognitive shortcuts that once worked well and continue to compare with newer, more accurate ways of thinking. The more I read, the more I realize that many study resources were designed around information, while very few were designed around how the mind actually learns. And that observation eventually became the seed of this notebook. What emerged was not a textbook, because textbooks already exist, and many of them are excellent. Nor was it a question bank, because question banks already test knowledge effectively. What slowly emerged was something closer to a cognitive scaffold, a structure designed not merely to deliver information, but to help information attach itself to other information, to return repeatedly in different forms, and eventually to become part of the reader's clinical thinking. In many ways, the notebook is less concentrated with teaching diseases than with teaching relationships. The relationship between symptoms and mechanisms, between patterns and diagnosis, between guidelines and decisions, between evidence and patient care. This is why the same concept appears repeatedly through the book. It may first appear as a patient sitting in clinic, later it returns as a table, then as a focused topic, then as a rule, then as a board style question. At first glance, this may seem repetitive. In reality, it is the educational architecture of the notebook itself. The idea is not to encounter a concept once and move on. The idea is to meet it repeatedly from different angles until it becomes increasingly difficult to forget and increasingly easy to recognize when it reappears in real life. Perhaps my favorite page in the entire notebook is not a disease page at all. It is the whole body map, not because it contains the most information, but because it reveals the philosophy behind everything that follows. Medical education traditionally divides the body into separate systems. Cardiology occupies one chapter, nephrology another, endocrinology another. Yet patients do not arrive divided into chapters. A diabetic patient may simultaneously be a cardiovascular patient, a nephrology patient, a vascular patient, and a preventive medicine patient. The whole body map attempts to reconnect what medical education often separates. It asks the learner to stop seeing isolated organs and start seeing interacting systems, feedback loops, biological currencies, and disease cascades. It encourages the question that experienced clinicians seem to ask instinctively, not simply what disease is this, but what mechanism is failing and what consequences should I expect next. The rest of the notebook follows the same philosophy. The case management notebooks transform information into decisions. The rules section attempt to compress complexity into memorable principles. The focus topics slow down and explore knowns. The active recall sections challenge retrieval rather than recognition. The recurring comparison tables place similar diseases side by side because the human brain learns differences more effectively when it can see them together. Even the recurring old reflex versus modern reflex sections serve a deeper purpose. They are not merely updates, they are deliberate attempts to help the reader replace outdated but deeply entrenched patterns with newer evidence based ones before those old patterns resurface during examinations or clinical practice. The quote on the cover states that family medicine is not choetic. At first glance, the statement may seem surprising. Family medicine often appears to be one of the most unpredictable fields in medicine. A single clinic session may include diabetes, depression, hypertension, dermatology, preventive care, pediatrics, women's health, and an undifferentiated symptom that could belong to almost any specialty. Yet the deeper one looks, the more one realizes that the apparent chaos is often the result of seeing disconnected facts rather than connected systems. Family medicine is not choetic, it is interconnected. Beneath the diversity of presentations lie recurring mechanisms, recurring patterns, recurring decisions, and recurring principles. The purpose of this notebook is to help make those connections visible. For board preparation, I hope this notebook series serves as more than a reference. Ideally, it becomes a framework for active study rather than reading passively. The learner can move repeatedly between cases, rules, focus topics, maps, comparisons, and recall questions. This repeated exposure from multiple perspectives strengthens retrieval pathways and mirrors the way board examinations test knowledge, not as isolated facts, but as clinical decisions, pattern recognition, and applied reasoning. By revisiting concepts in different formats, learners can identify weakness earlier, retain information longer, and improve their ability to retrieve knowledge quickly. Under examination pressure, success on exams is rarely determined by how much information was once studied. It is determined by how much can be accurately recalled and applied when it matters. Together, the four parts are designed to build a structured, exam focused clinical mindset by progressing from core system foundations to pattern recognition, localization, and finally integrated real world decision making across key areas of practice. Part 1 covers the major foundational systems and general principles, including cardiovascular, respiratory, endocrine, and metabolic systems. Along with core clinical guidelines and system-based frameworks. Part 2 focuses on internal medicine pattern recognition, covering gastrointestinal, hepatobiliary, renal, urinary, hematologic, and coagulation systems. Part 3 emphasizes localization and functional understanding, including musculoskeletal, dermatologic, neurologic, and pain-related systems, helping learners identify where problems originate and how they present. Part 4 integrates applied clinical practice across obstetrics and gynecology, pediatrics, surgery, emergency medicine, and preventive care, bringing together all systems into real-world decision making. Ultimately, my hope is that this series becomes a companion throughout training, not simply helping readers pass exams, but helping them think more clearly, connect information more effectively, and practice with greater confidence. If it succeeds, then it will have demonstrated the central idea behind the cover quote that family medicine is not a collection of random facts or endless complexity. It is a discipline built on patterns, relationships, and structure. Once those patterns become visible, learning becomes more efficient, examinations become more manageable, and clinical reasoning becomes far more intuitive. Before presenting part 1 specifically, I also want to be honest about the role of artificial intelligence in this work. AI was not the source of the idea, the clinical perspective, or the educational philosophy behind the series. The foundation of this work came from more than 2 years of long hours studying family medicine sources, solving board questions, engaging with American Academy of Family Physicians materials, and completing dozens of CME credits. Through this process, I was not only learning content, but also learning how exams think and how family medicine truly works. What became clear over time is that family medicine is wide, but it is not chaotic. It follows patterns. Examiners test patterns. Every topic has a structure. Every disease tells a story. Every exam trap follows a rule. And every patient presents a clue. True understanding comes not from memorizing isolated facts, but from recognizing these patterns, connecting pieces of knowledge, and seeing the whole system before focusing on individual details. It is about seeing the forest before defining the types of trees, and understanding the human body as an interconnected network rather than separate compartments. This is how a thoughtful family physician approaches patients, and this is how effective exam preparation should be built. AI tools were used as powerful assistants in this process, almost like an extended working team actually, helping with organization, rewriting, formatting, comparison tables, visual structuring, active recall conversion, and repeated refinement of ideas. However, AI did not replace the human effort. It amplified it. The responsibility remained entirely human, selecting the frameworks, identifying what matters, verifying clinical accuracy, aligning with guidelines, correcting errors, and shaping the final voice and purpose. I believe this reflects an essential skill of our time. Not to fear AI and not to contribute thinking to it, but to use it wisely to execute ideas with the clarity, structure, and efficiency that would otherwise require a full team and maybe 10 years of translating the idea into real work. Part 1 is an essential component of the series, but not the sole foundation, as other parts address equally important systems and perspectives in family medicine. It begins with the idea that family medicine becomes easier when we stop memorizing scattered topics and start seeing systems. This part focuses on the cardiovascular system, endocrinology, respiratory medicine, and imaging wisely, not as an isolated chapters, but as major clinical territories that family physicians encounter every day. The strength of part 1 is that it does not only list diseases, it teaches the learner how to approach them. In cardiology, for example, the chapter is organized around pump, pipes, rhythm, valves, vascular disease, risk, and prevention. It moves from maps and topic overviews into case management, hypertension, heart failure, ECG recognition, dyslipidemia, atrial fibrillation, pulmonary edema, cardiac testing, high-yield rules, and board-style stems. The method is deliberate. First, create the map, then build the mechanism, then apply the guideline, then test the decision. At the same time, this notebook is designed as a lecture note rather than a finished textbook. It intentionally leaves spaces for the reader to expand, refine, and personalize the content over time. For example, case management sections may be presented in a structured general framework rather than exhaustive detail. This is not a limitation, but a learning strategy. The goal is to first anchor a clear mental structure, then gradually add layers of detail with each review or clinical encounter. Every time the reader revisits a topic, they are encountered to write educational notes, clarify steps, add exceptions, and connect new knowledge to the existing framework. This process strengthens the brain networks by reinforcing the core structure while continuously enriching it with deeper understanding. The same philosophy continues across endocrinology and respiratory, where the aim is to recognize patterns, localize the problem, decide the best next step, and arrange follow up. The imaging section adds another essential family medicine skill. Not only knowing what imaging can show, but knowing when imaging is useful, when it is harmful, and when clinical judgment should come first. The source base was built from modern guideline thinking and trusted references, including contemporary cardiovascular guidance such as ACC-AHA, hypertension, acute coronary syndrome, chronic coronary disease, atrial fibrillation, heart failure, valvular disease, ESC concepts, chest and ASH thromboembolism guidance, USPSTF prevention logic, and similar guideline-based reasoning across the other systems. So part 1 is not simply a first volume. It is a key component of the series that trains the reader to think in mechanisms, patterns, scores, contraindications, red flags, prevention, follow-up, and border traps, exactly the way family medicine must be practiced and studied. Part 2 takes the series into a different kind of clinical territory. If Part 1 dealt heavily with the systems that often announce themselves through pressure, rhythm, breath, hormones, and imaging decisions, Part 2 moves into the quieter but equally dangerous domains of internal medicine: the gut, the liver, the kidney, the urinary tract, the blood, and coagulation. These are areas where the diagnosis is often hidden inside a lab pattern, a stool pattern, a urine sediment, a CBC abnormality, or a small clue in the history. The strength of this part is that it teaches the resident how to read those clues before they become complications. The gastroenterology and hepatology section begins from common family medicine presentations: dyspepsia, dysphagia, diarrhea, constipation, abdominal pain, GI bleeding, abnormal liver tests, jaundice, fatty liver, hepatitis, cirrhosis, and ascites. Then turns them into safe clinical pathways. It does not simply say GERD, IBS, or fatty liver. It asks, is there bleeding? Is there obstruction? Is there cancer risk? Is this functional or inflammatory? Is the liver injury hepatocellular, cholestatic, or mixed? Is this compensated cirrhosis, or the first sign of decompensation? This is why the section relies heavily on practical decision tools such as Glasgow Blatchford for upper GI bleeding, Rome 4 for IBS, BICEP for pancreatitis, FIB4 for metabolic steatotic liver disease, Childbug for and MELD for cirrhosis, Adderall and Lille for alcohol-associated hepatitis, and the PMN cutoff for spontaneous bacterial peritonitis. It also highlights modern treatment shifts, confirming H. pylori eradication, avoiding blind clarithromycin triple therapy, for example, recognizing when pancreatitis needs support rather than antibiotics, treating cholangitis with drainage, not antibiotic alone, and managing cirrhosis through prevention of variceal bleeding, cephalopathy, spontaneous bacterial peritonitis, hepatocellular carcinoma, renal injury, and transplant referral. The nephrology and urology section then changes the learner's eye from symptoms to filtration, urine, electrolytes, and risk over time. It builds the approach around AKI versus CKD, prenatal versus intrinsic versus post-renal causes, nephrotic versus nephrotic patterns, albuminuria, urine sediment, acid-base disorders, potassium and sodium emergencies, stones, dysuria, pyelonephritis, prostate disease, hematuria, enuresis, and CKD complications. Its value is that it trains the resident not to look at a creatinine as a single number, but as a story. What was the baseline? Is the kidney underperfused, inflamed, obstructed, scarred, or affected by medication? Is the urine showing blood, protein, casts, infection, or crystals. In family medicine, this is extremely important because CKD is often discovered before the patient feels sick, and early decisions about albuminuria, blood pressure control, SGLT2 inhibitors, RAS blockade, drug dosing, anemia, mineral bone disease, vaccination, and referral can change the long-term course of the patient. The hematology section adds another essential layer, how to think from the CBC. It teaches the resident to start with the lane, red cells, white cells, platelets, coagulation, thrombosis, or marrow, and then ask the right first question. In anemia, the question becomes what is the MCV and is the marrow responding? In leukocytosis or leukopenia, the question becomes is this reactive, infectious, drug related or malignant. In thrombocytopenia, the danger is not only bleeding but also TTP, HIT, DIC, marrow failure, and thrombosis. In clotting disorders, this section separates mucosal bleeding from deep tissue bleeding, platelet problems from factor problems, and provoked thrombosis from unprovoked or cancer-related thrombosis. This is especially powerful for board preparation because hematology questions often look like lab puzzle, but in real life they are safety questions. Who needs urgent admission? Who needs a smear now? Who needs a transfusion? Who needs anticoagulation? Who might have leukemia, myeloma, febrile neutropenia, thrombotic microangiopathy? The sources behind part 2 reflect that practical purpose. The GI and hepatology content is built around major guidance such as ACG, AGA, AASLD, bavenoportal hypertension principles, EASL drug-induced liver injury concepts, USPSTF and CRC screening guidance, and surgical guidance for acute abdomen. The nephrology and urology content draws from the KEDGO, CKD, AKI, glomerular disease, lupus nephritis, IgA nephropathy, ADPKD, ADA kidney risk management, hyperkalemia guidance, and IDSA, EAU urinary infection concepts. The hematology section uses ASH guidance, ISTH principles for TTP, IC and HIT, KIDGO anemia and CKD concept, IDSA febrile neutropenia principles, and oncology frameworks such as NCCN, ELN, ESMO, and IMWG criteria where appropriate. So part 2 adds a different intellectual skill to the series. It trains the learner to interpret hidden disease, the occult GI bleed behind iron deficiency, the cirrhosis behind low platelets and ascites, the glomerulonephritis behind hematuria and casts, the obstructed kidney behind rising creatinine, the myeloma behind anemia and renal dysfunction, and the dangerous platelet disorder behind what first appears to be just thrombocytopenia. Part 3 adds a very important dimension to the series, the ability to interpret pain, weakness, stiffness, neurologic symptoms, disability, and red flags. It focuses on musculoskeletal and rheumatology on one side, and the neurology and the neurosurgery on the other. These are areas where patients often present with broad complaints. My joints hurts, my back hurts, my hand is weak, I feel dizzy, I have a headache, or my leg is numb. The challenge for the family physician is to decide whether this is mechanical, inflammatory, infectious, autoimmune, vascular, neurologic, compressive, functional, or urgent. The musculoskeletal and rheumatology section is built around pattern recognition. It teaches the learner to separate inflammatory pain from mechanical pain, crystal arthritis from septic arthritis, true weakness from fatigue, systemic autoimmune disease from localized musculoskeletal problems, and fibromyalgia or chronic fatigue syndrome from destructive inflammatory disease. It covers high yield and high risk topics such as acute monoarthritis, gout, septic arthritis, rheumatoid arthritis, spondyloarthritis, SLE, Sjogren's syndrome, systemic sclerosis, myositis, polymyalgia rheumatica, giant cell arteritis, vasculitis, osteoarthritis, back pain, osteoporosis, fibromyalgia, regional musculoskeletal presentations, and safe use of rheumatology drugs. Its strength is that it repeatedly trains the resident to protect what matters most, the nephritis, and function in chronic pain and disability. The neurology section adds the skill of localization instead of treating neurology as a list of frightening diagnoses. It teaches the learner to ask, where is the lesion? How fast did it develop? Is this vascular? epileptic, inflammatory, degenerative, compressive, metabolic, or functional. It helps distinguish migraine from TIA, syncope from seizure, peripheral vertigo from posterior circulation stroke. Functional symptoms are from dangerous neurologic disease, and muscle disease from nerve, root, spinal cord, or brain disease. This is exactly the kind of reasoning family physicians need when they face headache, dizziness, weakness, numbness, tremor, memory complaints, seizure, stroke symptoms, or back pain with the neurologic signs. The sources behind Part 3 include major rheumatology and neurology guidance, such as ACR and EULAR recommendations for rheumatoid arthritis, SLE, lupus nephritis, psoriatic arthritis, axial spondyloarthritis, vasculitis, gout, and the others, along with guideline-based neurologic reasoning for stroke, headache, seizure, multiple sclerosis, imaging decision, and the neurological red flags. It also draws from core textbooks and board-style reasoning to translate complex topics into practical clinical decisions. Part 4 is the final and most exam-facing part of the series. It brings together the areas where family medicine must act with speed, precision, and practical judgment: obstetrics and gynecology, pediatrics, surgery, emergency medicine, and prevention. This part is designed as the high-yield table zone, a place for fast revision, red flags, best next step, screening intervals, emergency thresholds, and the traps that commonly decide board questions. The obstetrics and gynecology section organizes pregnancy and women's health through timing and danger. In obstetrics, it trains the resident to think by trimester, bleeding pattern, fetal status, maternal stability, delivery timing, and postpartum risk. It covers early pregnancy bleeding, ectopic pregnancy, antenatal screening, chronic hypertension and diabetes in pregnancy, preeclampsia, placenta previa, abruption, premature rupture of membrane, preterm labor, fetal growth restriction, shoulder dystocia, postpartum hemorrhage, and postpartum mood disorders. In gynecology, it moves through abnormal uterine bleeding, dysmenorrhea, fibroids, adenomyosis, endometriosis, PAP and HPV screening, breast disorders, contraception, emergency contraception, and gynecologic cancer clues. Its strength is that it teaches the resident to ask, is this normal physiology, a screening issue, a diagnosis, an emergency, or a delivery decision? The pediatric section adds the logic that children are not small adults. Age becomes part of the diagnosis. A newborn fever is not approached like a school-age fever. Infant vomiting, toddler injury, adolescent's mood symptoms, growth failure, developmental delay, vaccination gaps, respiratory distress, dehydration, limp, seizure, murmur, abuse concern, and safeguarding issues all require age-specific thinking. This section is especially useful because it begins every child with the appearance, work of breathing, circulation, age, weight, hydration, immunization status, feeding, urine output, growth chart, and safety screen. It teaches the family physician to protect the child before naming the disease. The surgery section then sharpens the resident's ability to recognize when a complaint has crossed from outpatient medicine into surgical territory. It covers acute abdomen, hepatobiliary and pancreatic disease, upper and lower GI surgical patterns, hernias, breast and endocrine surgery, vascular surgery, wounds, trauma, pediatric surgical emergencies, colon polyp surveillance, pre-op rules, and American Board of Family Medicine surgical traps. Its purpose is not to turn the resident into a surgeon, but to make referral and urgency smarter: who can be observed, who needs imaging, who needs antibiotics, who needs source control, and who must not be delayed. The emergency medicine section is built around resuscitation-first reasoning. It follows the logic of the undifferentiated patient. First, identify airway, breathing, circulation, mental status, shock, sepsis, bleeding, arrhythmia, stroke, trauma, poisoning, anaphylaxis, respiratory failure, pediatric arrest, and reversible causes. It trains the learner to treat and diagnose in parallel, reassess after every intervention, and decide safe disposition. This is the part that reminds us that in emergencies, the first question is not what is the final diagnosis, but what can kill this patient in the next few minutes, and what must I do now? Finally, the Prevention and USPSTF section closes the series with the true identity of family medicine, preventing diseases before it appears. It organizes screening, vaccination, cancer prevention, cardiovascular risk, pregnancy prevention measures, infectious disease screening, mental health screening, substance use, obesity, diabetes, osteoporosis, pediatric prevention, and USPSTF A and B recommendations. Its key message is very important for exams and real practice. First, define the exact population, confirm the patient is asymptomatic, then choose the correct preventive service. A screening question is not the same as a diagnostic workup. So, Part 4 completes the series by moving from knowledge and reasoning into action. It teaches what to do today, what not to miss, when to refer, when to screen, when to reassure, when to resuscitate, and when prevention is the best treatment. If the earlier parts built the structure of clinical thinking, Part 4 tests that structure under real family medicine pressure: pregnancy, childhood, surgical danger, emergency decisions, and prevention across the lifespan. At the end, I want to say that this is a human being before anything else. This series was not created because I wanted to produce another file or another collection of notes. It was created because a certain way of learning truly helped me, and I wanted to translate that inner process into something visible, organized, and useful for others. I tried to take the way I learned by connecting ideas, seeing patterns, returning to concepts repeatedly, asking what matters clinically, and modifying my understanding after every question, mistake, guideline, and patient encounter, and turn it into a structure that other residents can use, improve, and adapt. It is not perfect. It is not meant to be the final word in family medicine. It is living learning tool built with effort, reflection, correction, and genuine care. My hope is that it helps someone study with less chaos, think with more clarity, and feel that family medicine, despite its width, can be understood, organized, and practiced with confidence. Thank you.